Good afternoon. Welcome to the Health and Government Operations Committee. Chairman Pendergrass and the committee, we welcome you. Today's bill hearing will take place now. This is a virtual committee, so I ask for your patience if we encounter any technological or streaming issues. This bill hearing is being streamed on the Maryland General Assembly YouTube channel. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each individual panelist. Also, please keep your questions shorter than the expected answer. The bill sponsor or a designee is allowed 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes only in support. And then please stay in the hearing until the delegates have had an opportunity to ask questions. Next 5 witnesses will each be allowed to speak for 2 minutes in opposition and then respond to questions. So everyone gets a chance. Please conclude your remarks when you see the timer finish. And Richard, who's amazing, keeps the timing. Make sure you watch for it. Members must remain present with your video camera on during the entirety of the hearing. Those are the rules. And the bill order today, we're going to start with House Bill 578, followed by House Bill 669, followed by House Bill 765, 373, 699, and the last bill of the day will be House Bill 408. So we're going to start with House Bill 578. The sponsor is Delegate Kaiser. The title is Maryland Medical Assistance Programs, Prior Authorization for Drug Products to Treat an Opioid Use Disorder Prohibition. Delegate Kaiser, good afternoon.
Well, good afternoon to you, Madam Chair, and good afternoon to everyone on the committee. And I am sure, Madam Vice Chair, that you are familiar with this legislation since it is building off of successful legislation of yours from 2017. So it really mirrors what was done in 2017 that prohibited prior authorizations for medications for opioid use disorder. And now all we're trying to do is to extend that prohibition on prior authorizations for those enrolled in Maryland's public insurance program. So it's replicating that successful law of the vice chairs from 5 years ago. And I don't really think I need to talk much more about opioid use and opioid deaths and the challenges that and the harm that it's created within our state and across the nation. And treatment works, and we should really ensure that people get that and that they get the most effective medications. Unfortunately, the need for prior authorizations can slow that down. So again, just trying to extend on that 2017 law. We need to help all Marylanders in need who unfortunately have opioid use disorder. I do want to be clear that this is only for those with opioid use disorder. It's only for the medications used in addiction treatment and not, this bill's not talking about other medications. And really there's no more time to wait to ensure that we can provide these services and treatment. And so quite briefly, I do urge a favorable report on House Bill 578, and whatever extra time I have, I'd like to, I believe, give to Ann Seacott on my panel. Thank you.
My pleasure. And thank you for your leadership, Delegate. It's great to have you. We have Ann Seacott. Will you be so kind and get started? And you'll have Delegate Kaiser's time plus yours, and Richard will keep track of it.
Well, I very much appreciate that. I don't think I will need all of that time. But I'm Ann Seacott, representing the Maryland chapter of the National Council on Alcoholism and Drug Dependence in support of House Bill 578. We thank the sponsor for bringing it forward. And we too are grateful for what had been done way back in 2017. Just to put it in perspective, amid the COVID-19 pandemic, the pre-existing opioid overdose death crisis has worsened in Maryland. The number of opioid-related deaths increased by 20% between 2019 and 2020, and the preliminary data shows a continued increase between 20 and 21. The intent of this bill is to bring equity, as the sponsor said, to low-income Marylanders who are enrolled in Medicaid. this bill builds on what you have already established as policy in the state. I do want to also iterate what the sponsor said, that this does not apply to opioids used for pain. This is opioids. This is the opioid medications used in the treatment of opioid use disorders. Removing prior authorizations will allow people to receive medications deemed medically necessary by licensed healthcare practitioners. Currently, Medicaid's Pharmaceuticals and Therapeutics Committee annually reviews this and all classes of drugs and decides which ones get put on the preferred drug list and which ones will require a prior authorization. This bill is a policy statement that we believe, given the overdose death crisis in the state, that the need for consumers to have immediate access to medications when prescribers deem it medically necessary, that take precedent. We urge your support for the bill. And I would just also quickly like to add, I think that there might be a sponsor amendment. The bill as written applies not just to Medicaid, but to CHIP for children. And we had missed that and taking that out. There aren't very many minors who get this kind of medication. And we didn't want to say that shouldn't require some type of review. So with that, we ask for your favorable report.
Thank you so much for your testimony and for your advocacy. Next, we have Ms. Nancy Turner.
Hello, everyone. Good afternoon. Thank you for allowing my oral testimony in support of House Bill 578. I've been a provider for the last 20 years in the opiate outpatient methadone maintenance treatment programs. And I know how important it is to get someone help when they ask for it, that we're able to respond at the moment that they need it. Even the smallest delays in getting help can discourage and frustrate someone who is finally ready to seek help. For people with opioid use disorders, delaying access to medication means that a person starts to experience withdrawal symptoms. These withdrawal symptoms are flu-like symptoms that are usually intolerable to an opiate user. They then begin to use the illicit drugs rather than those that are approved for use for medication. Experts in the healthcare field are increasing their calls to eliminate barriers to treatment, including prior authorizations to medication. The General Assembly enacted this policy in 2017 for people with private insurances. While buprenorphine medications are generally accessible, there was a time a few years ago when Medicaid's Pharmaceutical and Therapeutics Committee switched medications that were preferred, meaning they did not require a prior authorization. This has changed, meaning that now prior authorizations are required. Providers have increased the amount of administrative time requesting authorization, sometimes having patients switch their medication. This is simply unnecessary, and passing House Bill 578 will prevent this from happening again. Thank you for your time.
Thank you for your testimony today. We appreciate it. Next, we have Mr. Joseph Adams.
Good afternoon, Chair Pendergrass and Vice Chair Pena-Melnick. Thank you. My name is Dr. Joseph Adams. I'm an addiction medicine physician, and I'm testifying in favor of HB 578 on behalf of the Maryland, D.C. Society of Addiction Medicine. Prior authorization for prescriptions by design create barriers to prescribing, and they work. But medication is central to the treatment of opioid use disorder, or OUD. OUD is unique. It's the only substance use disorder where the great majority, at least 80% of people with moderate to severe OUD, need medication. Stigma and misunderstanding about the role of medication is actually the #1 roadblock to effective OUD treatment. The best way to reduce opioid overdose is to improve access to effective treatment with medications. It's not just about distributing naloxone. As an example of the importance of medications, in France, when barriers to prescribing buprenorphine were essentially eliminated, prescriptions went up by tenfold and overdose dropped by 80%, which is astounding. We are in desperate need for new primary care providers to become willing to step up and treat OUD, but prior auth requirements just make this harder. Instead, we should be doing everything we can to reduce barriers to treatment. Medications are so important in OUD treatment that the term medication-assisted treatment is now out of favor in the literature because it implies that medication is something other than treatment. Access to medication should not be more difficult in people covered by Maryland Medicaid than it is for people with commercial insurance. We urge your support of HB 578. Thank you.
Thank you for being with us today, Doctor. We appreciate your testimony. I was given time for Ms. Nancy Rosencohen to be here. Did she get here yet, Richard?
No, ma'am.
Okay, so there are no other witnesses. Now we'll open it up for questions. Are there any questions from the committee? I see Delegate Kelly.
Thank you, Madam Chairman.
My
I
pleasure.
think probably this question is for Ann Seacott. Have you had a chance to see the letter from the Maryland Department of Health? It's confusing to me. So I'll ask the question. Their letter says that that this legislation is going to increase their costs because currently they get drug rebates by prescribing the brand name, and if they can't force people to prescribe the brand name, they're going to lose money. Can you comment on that?
Yes, thank you for the question. So the way that, and this does separate how things work in the commercial market and in Medicaid. But the way that this Pharmaceutical and Therapeutics Committee works when they review classes of drugs, part of the consideration is what the cost and what kind of rebates are given on any particular drug. And this happens in all the classes of medication. And so there are, and it's typically the branded medications where the companies work out deals with states and give a rebate on the back end. So whereas you and I think, oh, generic's always going to be cheaper for me to buy. And if I was going to the counter and I had a brand name and a generic of any drug, I'm probably going to pay less for a generic. But within Medicaid, because to me, the consumer, there's not a price difference, but to the state, there's a price difference. And so the state is saying, because of that rebate on the back end, the generics are actually more expensive for the state. So that's where that potential fiscal impact comes from.
Brief follow-up, if I may, Madam Chair.
Absolutely.
So just to be clear, though, the prior auth barrier then with Medicaid right now is on the generics, not on the brand name. So if people were to prescribe the brand name, there would be no prior auth, but that information, obviously we have a wide network of providers, so we still need this legislation because of that.
And so one of the reasons also for the legislation is because this is an annual review by the P&T committee. And we did have an incident a few years back where there was a switch and providers and their patients either had to add on this prior authorization process or switch medications. So this is also sort of meant to make sure that doesn't happen again.
Very helpful. Thank you so much.
Thank you, Delegate. I appreciate your questions. We have next Delegate Krebs, followed by Delegate Hill.
Thank you. I'm not sure if anybody's on here that can explain it, but when I read the fiscal note about this whole rebate thing, I still can't understand what is the net cost to the state. I mean, this is something we should be doing. I thought we already did it in 2017, but obviously the way the fiscal note reads, maybe this is a question for our subcommittee, get someone in to explain the whole rebate process, because it doesn't make sense to me. Maryland Department of Health basically says, OUD prescriptions dispensed outside of an office visit are considered preferred drug and is available without prior authorization. So we need to find out why this happens to be about the cost. Why is it about the rebate versus about what's the right thing to prescribe for whom? And I'm not sure if Ann understands it or not, but why can't we get rebates on these other drugs? I mean, can't we negotiate rebates on what we need for our consumers?
I don't feel qualified I don't know enough about how the generic drug market works to know why it doesn't happen with the generic drugs. But I'm
Right.
sure that's information we can make sure happens at the subcommittee.
Well, I think we need to understand as a committee, because it doesn't make sense to me. And the rebates are always a question that none of us really have an answer. Nobody, I don't think any of us understand it the way we need to, but thank you.
Thank you, Delegate Cripps, and we'll make a note to perhaps have someone talk to us about it, okay? That's a good point. And we have Delegate Hill, followed by Delegate Bandari.
Thank you, Madam Chair. Thank you
My
for this
pleasure.
bill. So, Anne, I'm going to direct this to you. It's sort of a follow-up to the previous two questions. I'm not clear if what you're saying, the other way that MDH can get cheaper is to do a subscription model, where they, with the manufacturers, like some people have done with hepatitis drugs. And that is not, it's more straightforward, and we can transparent and all that kind of stuff. And it's not based on rebates. But my question is, if we want to address, I'm sorry, let me back up. And part of this is because I think most people in this committee know that I hate pre-authorization, but I'm also very caught up in the idea that drug manufacturers manufacture the drugs that addict us, and then we pay them for the drugs to get us off our addictions. So it sounds like what you're saying is MDH has been using pre-authorization to deny generic prescriptions and require that the prescriber then go through represcribing as a name brand in order to get this money. And if that is true, could we not simply say that, the reverse of what we usually do? Usually we say, if you do that, everything's supposed to be filled in a generic, unless the physician or prescriber stipulates that it has to be name brand. Could we say within this bill that for these medications, this class of medications, only name brand is to be given? And that way, you don't have to pre-authorize it. It's automated that if you write for the drug, no matter what name you use under this program, you're going to get the name brand.
I think in essence, what you are describing is what current practice largely is. That right now, the brand name drugs are on the preferred drug list. They're the ones that every year there gets to be a decision whether or not they stay on that list. So I think you'd be saying sort of codifying existing practice.
I think it goes a little bit more, if I may, Madam Chair, simply because
Yes.
there's an assumption that prescribers look at that list. We don't. We write the drug. We don't even necessarily know the person's insurance. Sometimes we do, sometimes we don't. And what happens at the pharmacy is, and so this would be really a directive to the pharmacy, that for this insurance, this is to be filled by the brand name. We don't look at those lists. We write our prescriptions for the same as we would unless we have enforced. So that's why they go through the pre-authorization, to push it back at us and make us write another prescription. So that would be the idea. And so it's codifying, but it's actually telling the pharmacist, when you get this prescription, this is how you should fill it. It's an exception to the rule that has you filling it generically. For these drugs, fill it the other way.
Thank you, Delegate Hill, for explaining it really clearly from a practical perspective. We really appreciate it. Delegate Bandari, followed by Delegate Bagno.
Thank you, Madam Chair. This is
pleasure.
a follow-up question to the Department of Health letter. And they refer to the clinical concern regarding the removal of prior authorization from certain these OUD drugs. And they have given the example that if it is injectable, the OUD treatments are taken prior to completion of clinical evaluation, the patient can experience a medical crisis due to sudden withdrawal. I wonder if it is a data-driven conclusion. Could you share your wisdom here?
So there's a bit I've been learning about how some of this works. And so the oral medications that are tablets or film or liquid, I think are the ones that are the most prescribed. There are some injectable forms of the medication. This is where I think really should have the department participating and answer some of the questions. The injectable drugs that are currently on the preferred drug list still have clinical criteria requirements. So there are still things, and I don't know if Dr. Adams, I know you like one person to answer, so maybe a question could be directed to Dr. Adams. I don't know if he does any of the injectable drugs, but there are still some requirements, additional requirements that have to be met for certain, again, these apply to all kinds of classes of drugs that still have a clinical requirement, but it isn't an actual prior authorization. So we're not talking about addressing any of those, changing any of that.
Thank you.
And we'll invite, as always, the department to the subcommittee if the bill is assigned to the subcommittee. Thank you. Delegate Bagno.
Thank you, Madam Chair, and thank you for this bill. I apologize because this really should be a question directed to the department. But from a provider perspective, whoever feels most qualified to answer this, for the purposes of this bill, preferred and non-preferred is defined by the rebates, not by outcomes or what is the most appropriate treatment option. Is that correct? Is there a preferred because it's more clinically relevant, or is it preferred because of the financial implications?
Hi, this is Dr. Adams. I think it's not Suboxone, which is the brand that gets the rebate for MDH, is not clinically preferred. I think it's just because the manufacturer was able to make that deal.
Thank you. Thank you very much, Madam Chair.
Thank you, Dr. Adams, for answering. Thank you, Delegate, for the question. Are there any other questions for this bill? Seeing none, this concludes the bill hearing on House Bill 578. Thank you, Delegate Kaiser, and everyone for being here. Next, we're going to go on to House Bill 669, Delegate Wilkins, Maryland Medical Assistance Program, doula services coverage. Good afternoon, Delegate.
Good afternoon, Madam Vice Chair and members of the committee. Thank you for the opportunity to present HB 669. For the record, I am Delegate Janelle Wilkins, and I'm pleased to present this bill. This bill brings great news to this committee, and I think to our state. After years of collective work on this issue, the Maryland Department of Health is rolling out a Medicaid reimbursement program that will allow reimbursement for certified doulas. And as we all know, this will really ensure that low-income birthing parents will have greater access to doula services, where research shows us that there are positive outcomes for patients who work with doulas, especially patients of color and those with lower socioeconomic status. And just for a little bit of background, about 2 years ago, I introduced a bill to study the best way for Maryland to move forward with doing doula Medicaid reimbursement and creating a program like this. And this committee instructed the Maryland Department of Health to further study the issue and take it on, which was greatly appreciated. I was really glad to be a part of the work of the Doula Technical Advisory Assistance Group that studied this issue last year. We looked at everything from the payment, the types of services, the certification programs, mistakes and challenges from other states. And at the same time, the Department of Health actually received funding and started taking steps to put a doula reimbursement program into place. And so this bill actually just codifies the Medicaid reimbursement program for doulas. The bill is really critical to ensuring long-term access for doulas for low-income women and birthing individuals who participate in Medicaid. Hiring a doula can be out of reach for many families due to the cost. And we know that doulas spend significant time with their clients. They're doing life-saving work. And it's critical that we ensure that there is greater access to their services. This bill strikes a careful balance to ensure that there's flexibility for the Maryland Department of Health while mirroring their regulations. And it just codifies their existing regulations for this program into law so that we can ensure this is a permanent, long-lasting program. I'm proud to have worked with the Maryland Department of Health on this bill, and I want to thank them for their diligent work, their leadership on this, and the inclusion of many stakeholders. The bill is supported by MDH with 2 technical amendments, which I have submitted to the committee. And I also want to note support from doulas across the state, from MedChi, ACOG, Public Justice Center, and the Maryland Hospital Association, among other supporters for this legislation. I urge a favorable report on HB 669. Thank you.
Thank you, Delegate Wilkins, for presenting your bill, and the committee appreciates you meeting with everyone involved in working it out. Thank you so much. Next, we have Ashley Black. Ms. Black.
Good afternoon, committee members. My name is Ashley Black. I lead the Access to Health and Public Benefits Project at the Public Justice Center. You have our written testimony. We support House Bill 669, which, as you've heard, would codify the doula regulations and afford Medicaid beneficiaries access to doula care during pregnancy, birth, and postpartum. Doula care is a vital strategy to addressing maternal mortality and morbidity in Maryland. Our state has made some progress in bringing down the overall maternal mortality rate, but there are still significant disparities in maternal health outcomes between Black birthing people and their white counterparts. Research supports that doula care can help improve health outcomes, not only for the birthing parent, but also for the baby. Babies born to birthing people who receive doula care tend to have higher infant birth weight and higher breastfeeding initiation rates, among other benefits. So we're thankful to MDH and Maryland Medicaid for committing to reimbursing doula services for Medicaid beneficiaries. The program, as you heard, began its rollout last month, allowing Maryland to actually join several other states as a leader in expanding Medicaid to cover doula services. We're aware of the amendment to change the definition of postpartum from 60 days to a full year to match the regulations. We do believe that nicely complements other legislation that this committee has passed to extend postpartum coverage for dental and behavioral health services from 60 days to a full year. Thank you, and we urge a favorable report for House Bill 669, and we do look forward to working with Delegate Wilkins, this committee, and other stakeholders on expanding access to doulas.
Thank you, Ms. Black. We appreciate your testimony. Next, we have Ms. Pam Casemeyer.
Hello, members of the committee. Pam Casemeyer here on behalf of MedChi and ACOG as well. And we're very pleased to be here in support of this legislation. I'm going to give you back some of my time because I'm basically in Me Too. I did want to say and acknowledge Delegate Wilkins and other stakeholders on the call, because as you know, the original legislation we had some concerns about unintended consequences, language issues, other kinds of things. But this task force or work group that worked over the last year or two did a stellar job at framing something that really provides a program and support for pregnant women and their children that should be very effective in helping our collective ongoing efforts with maternal morbidity and mortality and safe pregnancies and the like. So we're very pleased it does codify the regulations, which sometimes we do and sometimes we don't, but it has, it tracks it very well. And we also are very pleased and supportive of the suggested amendments from the department and all of their work on this issue.
Thank you so much for always working with the committee. We really appreciate your efforts. Next, we have Ms. Patricia Liggins. Patricia Liggins.
Yes. Hello, everyone. My name is Patricia Liggins. I'm here on behalf of Birth Supporters United. For many years, the Maryland maternal health space has addressed several different solutions in which our state can improve outcomes for the people who live and build their families in the state's communities. As of last year, the state of Maryland has enacted an amazing first step toward addressing those maternal health outcomes as they relate to families who simultaneously battle disparities as a result of race and socioeconomic status. This bill is simply created to ensure that the solution that is evidence-based and effective for both the families giving birth and the medical care systems in place is something that continues onward into the future. And for this reason, Birth Supporters United is testifying in favor of HB 669. Thank you.
Thank you so much for your testimony, Ms. Liggins. Next, we have Ms. Andrea Williams Mohammed. Good afternoon.
Good afternoon to the chairs and members committee. Thank you, Delegate Wilkins, for your dedication to the support of birthing families in Maryland and for giving me the opportunity to speak in support of this bill. I am Andrea Williams Mohammed, Director of the Missouri Malkia Birth Collective, a doula and a trainer working in the state of Maryland for over 20 years. And I'm also one of the co-chairs of the Doula Technical Assistance Advisory Group that work with local and state stakeholders to get to this agreeable program. I stand in support of HB 669 as a priority in addressing the high rates of disparities within the minoritized communities in our state. With rates slightly above the national average, Black, Brown, and Indigenous birthing persons are dying at rates 3 to 4 times more than their white counterpart. This bill lays the foundation for the recognition of the work already being done in community, as well as creating pathways for this support to continue and to be integrated into our current hospital and medical system. It also sets the state on a pathway for lower costs associated with maternal care, and is also linked to an increased rate in breastfeeding. My only concern, any legislation that is passed, I stand that it should place an emphasis and require Maryland Medicaid to take a close look at the pathways in which it is creating, that it is inclusive, equitable, and creates a diverse workforce. I stand in favor and support of this bill and look forward to continuing my work with Delegate Wilkins and the other stakeholders and getting this into reality. Thank you.
So this ends the bill, actually the testimony on the favorable. So we have an unfavorable, but we're going to ask questions first of the favorable panel. Are there any questions for the favorable panel? I don't see, actually, did I see one? 1 second. Apologize, I thought I saw one. I don't see any. Oh, yes, the hand is too light, Delegate Hill. You have to make that a little darker.
All right.
Go ahead.
Okay. Yeah, I wanted to go to HSCRC. I know that Delegate Wilkins discussed working things out with MDH. HSCRC's letter suggests that they're rolling out a program to do this reimbursement, and that by putting it into statute instead of leaving it for a while in regulation, the flexibility that they need will be compromised. They also, and so they think this is A, not necessary right now, B, potentially problematic. And they also speak to, so the HSCRC has a maternal and child health funding initiative to fund programs initiatives by MDH. And I'll read it as a portion of the initiative's $40 million in cumulative funding for 4 years through FY25 will be directed to supporting doula services for Medicaid beneficiaries. And HSCRC does not need the statutory change in this bill to continue this funding. And then they also have issues with the term medically necessary and the inclusiveness of payment rates. So they have issues, and I just wanted to know if you've had an opportunity to review their letter, if these issues have been addressed, or if you have a response at this time.
Thank you, Delegate Hill, for the question. So I just became aware of this before the bill hearing. But in terms of HSCRC, first of all, thank you to them because they are funding this rollout in the next few years of the program. So really appreciative of the work of HSCRC and the Maryland Department of Health. I do need to follow up with them because I know that they mentioned that there's payment rate language. I just want to make sure that they are looking at the right bill and the bill language that's in this bill. Because we don't include the payment rate in this bill. We want to make sure that that's flexible for the Maryland Department of Health and that that's something that they can do by regulation. And so I think this can be resolved by just a direct conversation, but this is the first time that I'm hearing today that I'm hearing about the concern from HSCRC. So I think it's just a quick follow-up to make sure.
Super, and it may even be a delay in the bill, so you pass the bill and have maybe a start date after their funding runs out or something like that, but I'm sure you can figure it out. Thank you, Madam Chair.
Thank you. And Delegate Wilkins, if you can just follow up with Mr. Stefan, that would be wonderful. And then please let me know, okay? Thank you, Delegate, for the question, Delegate Hill. It was an excellent question. Any other questions? Seeing none, we're now going to go on to the unfavorable panel, and we have Ms. Laura Bugley. Ms. Bugley, good afternoon.
Thank you, Madam Vice Chair, members of the committee. I'm Laura,
My pleasure.
Legislative Director for Maryland Right to Life. We applaud any sincere efforts to improve birth and delivery outcomes for women in Maryland. We oppose this bill as written because it deceptively speaks to pregnancy and birthing person without disclosing that it will allow abortion providers to receive public tax dollars for operating as full spectrum doulas. Abortion increases incidence of future pregnancy complications, preterm births, and miscarriage. That's important to note. By definition and longstanding tradition, doulas are non-medical support providers who complement licensed medical professionals in improving birth and delivery outcomes, not in terminating pregnancies. With this bill, you will be authorizing the Department of Health to certify abortion doulas, among others, as authorized medical providers who will then become eligible for Medicaid reimbursement. You also will be enabling the proliferation of dangerous chemical abortion drugs throughout our state. This bill will have the effect of reducing the standard of medical care and subjecting pregnant women to greater risk of maternal injury and death. This bill also fails to provide a conscious clause to protect doulas who, for moral, religious, or ethical reasons, do not want to participate in abortion. As a result, many legitimate doulas, and particularly faith-based doula organizations, may be forced to discontinue their service ministries in Maryland. By approving this bill, the state will be diverting critical funds away from legitimate providers of prenatal care and forcing taxpayers to further subsidize the $2 billion abortion industry. We respectfully urge you to put pregnant patients before abortion profits and to issue an unfavorable report on this bill as written. And I encourage you to continue to improve it, to focus it specifically on healthy birth and delivery outcomes. Thank you.
Thank you for your testimony today. We appreciate it. Are there any questions for this panelist? Delegate Shalega.
Thank you. My question
pleasure.
actually for Pam Casemeyer. Are you still on here?
Yes.
There you are. Sorry again. It's like the Brady Bunch
okay.
squares. It's so hard. They're tiny. Hey,
That's okay.
Pam, that a good point I think was made about, I don't think I'm using the right term, not conscientious objectors, but physicians who are not required to do abortions, or anesthesiologists who are do not want to do abortion. There's a term, refresh our memory of that term, and would that apply to doulas who do not want to be involved in the abortion industry?
There is nothing in this bill that I see that creates any requirement, obligation, involvement at all by doulas in the abortion service area, unless that is their choice for their practice.
But what, can you tell me what the correct term is for that? It's not conscientious objector. That's obviously.
I have to admit, I don't know that
there is a
term they use that's a legal term. But
we can find that out offline.
Yeah, there is.
Okay. Yeah. We'll find that out offline.
Yeah.
Okay.
Because
All
you don't
right.
know it and I don't want to put you on the spot.
Yeah,
So
I
we'll
don't need,
find
yeah,
out.
exactly. I don't want to put
Yeah.
anybody on the spot who doesn't know it either, but thank you so much.
My pleasure. And thank you for the question, Delegate. I'll make a note of it so we can find out. Next, we have Delegate Rosenberg, followed by Chairman Pendergrass.
I would just briefly say, I believe it's a religious exemption. Thank you.
And the delegates saying no. We'll find out. We'll find out. Delegate Chairman Pendergrass.
Thank you, Madam Chair.
My pleasure.
Pam Casemeyer, I'm wondering where the idea that doulas have prescribing authority comes from in someone's mind, because in my memory, doulas do not prescribe any kind of medication. Would that be accurate?
Yes, there's nothing in this bill or this structure or this program that provides them prescribing authority.
Do doulas at this time have prescribing authority anywhere in state code that you know of?
Not that I'm aware of.
Right. We're pretty careful about who gets prescribing authority and who doesn't. Usually it's advanced practice nurses. So maybe some of those comments may have been from a misunderstanding. Thank you.
Thank you, Chairman, for clarifying that. That's important. Any other questions from the committee members? I'm so sorry, but witnesses are not allowed to ask questions. We apologize. You can contact us offline. I don't see any other question for this bill. So this concludes the bill hearing on House Bill 669. Thank you, everyone, for your testimony today. Now we're going to go on to House Bill 765, which is Delegate Bridges, Maryland Medical Assistance Program, doula program. Good afternoon, Delegate Bridges. Will you be so kind and get started?
Thank you, Madam Chair, and good afternoon.
Pleasure.
Good afternoon to the members of the Health and Government Operations Committee. For the record, once again, Delegate Tony Bridges presenting House Bill 765 before your committee today. It's a bill that you have heard recently as early as a few minutes ago. It's very similar to the doula bill that you just heard. In fact, this bill was actually brought to this committee over the last couple of years by Senator Ellis. When he introduced it as a pilot. Since then, it's changed a little bit. And the purpose is really to do exactly, again, what was stated from the last bill hearing that you heard, to really make sure that we build on the state's progress related to maternal and child care, health, and wellness. And so I will not talk to you about all the great things that you heard already about why this is needed in terms of having doulas or the health inequities, but I will mention that, you know, the CDC, just as one example, mentions that Black women are 3 more times likely to die from pregnancy-related deaths than white women. And even more so, the CDC states that 2/3 of these deaths are avoidable. And so Black women are much less likely to receive prenatal care in the first trimester and at more risk for more hypertensive and other sort of issues. And so with this state-sponsored support, I believe that we can help with Black women and all women to have better likelihood of better health outcomes. And so that's what this doula program is once again about. You heard, again, a lot of the information about why this is also needed. But what I will say is different about this bill versus what you heard in the other bill is that this bill goes a little bit further in actually naming some of the doulas and the doula programs. It talks a little bit more about specifics in terms of protocols with how people get paid from those programs. And it goes a little bit out of the range of what was stated recently from the last bill sponsor. What I will say is that, you know, this, although it does go a little bit further, the sponsor, myself, and I'm willing to work with the last bill sponsor to make sure that we get this right. This is really an important bill and an important program, and we want to do all we can to help with reproductive justice. And so because of that, we do have support, of course, for this bill. I know that Laura Wyatt is here from Black Girls Vote, which is a nonpartisan national organization designed to represent the concerns and interests of Black women, and also Reproductive Justice Inside, which is a statewide project to address the Services needs is also here or may have submitted written testimony. Just in closing, by passing this bill, we can ensure the survival of the doula program despite expected changes in our executive branch. It's a very important program, and I will commit for this committee, for your benefit, and to save you on asking a lot of questions if you don't have to, I'll commit to work with the sponsor of the last bill, as well as the folks from the Doula Technical Assistance Advisory Committee, to make sure that we get this right. We want to make sure that we have a good bill. More than that, we want to make sure that we have a good doula program for the state of Maryland. And so with that, Madam Chair, I will conclude my comments, and I'm more than happy to take any questions that anyone has. Again, we have Laura Wyatt here from Black Girls Vote who would like to speak in support of the bill. But again, I can assure this committee that I'll be working with the sponsor of the last bill, as well as the Senate sponsor, to ensure that the doula program actually moves forward and we can come to some consensus.
Thank you so much. We really appreciate it and appreciate your testimony. Ms. Lauren Wyatt, are you here?
Yes, I'm here.
Good afternoon.
Hi. Thank you. Position favorable. My name is Lauren Wyatt, and I'm the advocacy lead for Black Girls Vote Incorporated, a nonpartisan nonprofit organization committed to engaging, educating, and empowering Black women to activate their voice by using their vote. I first would like to thank the Health and Government Operations Committee for the opportunity to share why this issue is important to our organization. Black Girls Vote has 4 main pillars: voting rights, economic empowerment, education, and healthcare, which makes Black maternal health and wellness one of our main focus areas. So really quickly, I'm going to tell you why HB 765, which establishes the Maryland Medical Assistance Program, doula program, should be passed. According to the Center for Disease Control, Black women are disproportionately affected by maternal mortality. For every 1,000 live births, about 40 are victim to pregnancy-related deaths. That is 3 times more than the rate for white women. Also, 2/3 of those deaths are avoidable. Also, 2/3 of those deaths are avoidable. Black women are much more likely to receive no prenatal care or to receive it later than the first trimester than women of any race besides American Indian, Alaska Native, and Native Hawaiian. Black women are more likely to suffer from hypertension and preeclampsia, which increases the chances of adverse health outcomes for both mothers and babies. So the question is, what can doulas do to help address these issues? There is research to suggest that continued support like doula services reduce the needs for cesareans and instrumental birth. Also, oftentimes Black women's pain is not taken into consideration. A doula that is familiar with the expecting parent is able to help the patient identify concerns and get help in a more timely manner. While doulas do focus on the baby, they provide physical and emotional support to the parents as well, which makes for a happy mom and a happy baby. I encourage the committee to not only listen to me and other witnesses, but to simply listen to the research. Research is calling us to act now. If we want to end Black maternal mortality, it is essential for us to make sure that doula services are available, affordable, and covered under health care plans as well. This bill is a call to action. We all have a role to play in ending Black maternal and infant mortality. Voting yes is a big step in the right direction. Thank you all again for the opportunity to speak before this committee. We urge a favorable report for HB 765. Thank you again.
Thank you so much for your advocacy. Are there any questions for this panel of favorable? Okay, I don't see any. Thank you so much for your testimony. Now we go on to a panel of unfavorable. First, we have Ms. Laura Boagley.
Thank you again, Madam Vice Chair. Laura.
My pleasure.
Legislative Director for Maryland Right to Life. I don't want to waste your time with just repeating the exact same testimony, although the bills are nearly identical. So I just want to make some comments about the things the bill sponsors mentioned during testimony today. So we do again support any efforts to support doulas in healthy birth and delivery outcomes. The bill is essentially the same as Delegate Wilkins' bill, but this bill was the original bill. And Maryland Right to Life has opposed this now over the last 3 sessions. The first year, the bill sponsor and other proponents denied that it even applied to abortion doulas or that abortion doulas even existed. That was despite the fact that the Baltimore Doula Project, which does assist in abortions, admits that they assist in abortions and advertises that they assist in abortions, was one of the leading proponents. As you know, again, we have proponents this year that support full spectrum abortion doula services. But now they're acknowledging that. So Delegate Bridges is correct that the main difference in this bill is that this bill lists the doula certifying organizations, which includes full spectrum doula programs. And again, full spectrum doula is a new branding for abortion coaches or people that are trained and paid to basically provide emotional support to women while they're undergoing an abortion. So the previous bill and this bill will authorize abortion doulas to be reimbursed through public tax dollars for assisting in abortion, whether it's through surgical or chemical. They're already doing that in Maryland. This bill must be considered with the overall agenda of abortion advocates this year, which includes the Abortion Care Access Act and several other incremental smaller pieces of legislation to expand the scope of medical practice of non-physicians and lower-level healthcare workers so that they are authorized to prescribe chemical abortion pills and be reimbursed. So again, we salute any effort to improve healthy birth and delivery outcomes there. I think if you tighten up this bill and the program just a little bit and include the participation of a wider variety of certifying organizations in the program to come up with the standards so that you can be more inclusive and not discourage the participation of doula ministries in Maryland, then the bill could be something worth passing. So I again, urge you to vote no on the bill in its current state and continue to improve on it. Thank you.
Thank you very much. Next we have Pam Casemeyer.
Hello, members of the committee. I must say, in fairness to Delegate Bridges, who I talked about with this, I could have been, I suppose, support with amendment, but when these two bills came in, I just felt it was necessary in case there was any confusion through the hearing. We are very supportive of the objective of this bill, exactly like I said for the last bill. As you heard, this was a reintroduction of the bill that originally came in that then caused the formation of the task force that sat down and put the structure together. And the other bill really reflects the regulatory structure that the group came out of. This bill doesn't have tremendous what concerned us about this bill when we read it, as you all know, having served for quite a while, statutory language is not necessarily as detailed and granular as regulations because, for instance, Delegate Bridges' bill includes how much the payment rate is, or includes the list of organizations. So every time you want to change any aspect of the program, you have to come in and change the statute. So we just wanted to point out that the intention is the same. Delegate Bridges, objectives are the same. We know where this came from, but wanted to be very clear that the language in the other bill is really the better structure for moving this program forward, and didn't want that message to get lost. That's why I said opposed as opposed to support with amendment. And again, thank you, Delegate Bridges, for your leadership. My opposition, as you know, we discussed, is not relative to your intentions.
Thank you so much. I'm now going to open it up for questions, and we have Delegate Kipke followed by Delegate Shalega.
Thank you, Madam Chairman.
My pleasure.
I just want to thank the sponsor for his comments referring to pregnant women. I think it's really important that we don't erase women out of birthing. It's, as someone who's supported my wife through 3 home births, I can tell you it's one of the most incredible things to see your wife, how powerful they are, and it's just amazing. And for the small number of people who live out their lives as another gender, I don't think we need to erase women from this conversation, and I find it insulting every single time I hear it done respectfully. But my question is for Laura Bogley. In my research on doulas, especially as related to the term abortion doula, please correct me if I'm wrong, and please send me any information that you have. But abortion doula, as far as I can tell, doesn't do any of the medical aspects of abortion. From what I'm able to find in the research that I've done is that they do like sort of emotional support for people who have had an abortion prior to their interaction with them, or maybe even, in conversations with them. But is it true, or am I wrong, that they don't actually do abortion services?
That's true in theory, if they are complying with the law, Delegate, that's true. But this bill would change that and expand the scope to elevate them to a position of a medical provider who is authorized to provide medically necessary services. So I don't know how you can be a non-medical provider and provide medically necessary services that are reimbursable through Medicaid.
So can you show any evidence, even after this hearing, please, that beyond what I've said, emotional support, that kind of stuff, that they're actually involved in medical abortions anywhere in the country, and just specifically in the actual abortion itself, not talking about the abortion, not the mental and emotional stress of it and recovery from it, but the actual abortion itself. I'm really curious of that, because it sounds like you're saying that this bill will allow them to perform abortions. However, I'm struggling to find, it seems like that would be a violation of law. It seems like that's outside of the scope of what they are legally allowed to do. And I'd really like clarity on it. That's what you're telling us, but I can't find that in my research. So if you could please give us some.
I'll be happy to resend that to you, Delegate. Again, it's in context of the overall agenda. The Abortion Care Access Act and other bills will remove the physician-only requirement that's in the code. This year, they have the votes to do that. And in terms of actual evidence to show that they're currently violating law and actually performing surgical abortions or providing chemical abortions, we have lots of incidents of the facts that non-physicians are distributing chemical abortion pills. And now the FDA has allowed that by removing safeguards for that. But in terms of finding actual violations where they're participating in surgical abortions, that's something that would be a burden on the Maryland Department of Health to investigate and provide that information. But as you know, Maryland is one of only 3 states that does not require abortion providers to report the number of abortions that they commit or the nature reason for. We only have those numbers when they file for reimbursement through Medicaid.
Just as a quick follow-up, Madam Chair, if it's okay.
Sure.
They are not allowed to prescribe.
Currently.
Unless this legislature allows them to prescribe. And this bill doesn't do this, neither does the prior bill. So they're not allowed to prescribe, correct?
Currently, they're not allowed to prescribe, but the way that they have been operating, they haven't needed to prescribe. They have what they call a signing physician, or they work in consultation or under supervision of a signing physician, someone that provides authorization for one clinic or multiple clinics. And that has been deemed sufficient. Now, the FDA had already removed the physician-only requirements. So what they're looking to do now is codify that in Maryland law so that those people become eligible for Medicaid reimbursements for distributing chemical abortion pills.
All right, well, I need to keep doing some homework on this. Thank you.
You're welcome. Thank you.
I have Delegate Shilega, followed by Delegate Kelly.
Thank you. And this
My pleasure.
question, I think would go to Laura Bogley. So you heard my question in the last bill, and I'm glad to hear that you're very supportive of doulas and, the birthing experience for women, because women have babies, not people. And I think the word you used in your testimony, I actually found it was conscious clause, or I think it could also be called conscious protection. Is that where we were trying to go? I was trying to go in the last bill hearing.
I think Delegate Shilega, all of the above terms that you have used are correct and appropriate. So conscience clause or conscience protections you're right, it's for conscience objectors, but it's basically an extension of First Amendment privileges, including religious freedoms, but it's broader than religious freedoms. So a conscience objection can be based on not just religious beliefs, but on moral or ethical standards. And that's why 9 out of 10 current OBGYNs will not commit abortions for ethical reasons. And that's why now they're looking to the proliferation of lower level healthcare workers distributing chemical abortion pills because the doctors won't do it.
And the language that actually the vice chair texted me, that I love technology when it works, is the 22-14 Health General a person may not be required to perform an abortion, but the doula would not be actually performing the abortion. They would be in the room holding the woman's hand as she's getting an abortion, and that would be the abortion doula. So, we probably need some language, as you pointed out in your testimony, to tighten that up.
I recommend it, Delegate, in any bill that expands the scope of practice for medical providers.
Thank you.
Delegate Kelly.
Thank you so much. And I don't think we need to continue this conversation too long. I just wanted to clarify with Laura, because what Ms. Bogley, what you described in terms of the Abortion Care Access Act, which the committee will hear later, was physician assistants, which is a very different classification than doula. So I think the concern you have is not with the doulas and their agreement with physicians that we'll be considering later, but with physician assistants. So I just, isn't that so? That your concern is that this legislature in a separate bill will be looking at those folks who do have prescriptive authority, and that doulas are not the same as physician assistants.
Right. So as I said, Delegate Kelly, there are several bills. Some are smaller, incremental. The Abortion Care Access Act, as you know, with your other bill, of which you're the sponsor, are broader, but there are several smaller incremental bills, and I'm asking the committee to look at that agenda overall, and that there's obviously an effort here to expand the scope of medical practice for greater numbers of non-physicians. Eventually, it may be doulas. Right now, we know it's nurse midwives, certified nurse midwives, nurse anesthetists, physician's assistants, a whole laundry list, fill in the blank. Doulas may soon follow, or they can continue to do that under certified medical providers. So we ask you to look at the overall agenda and focus and prioritize public funding for those prenatal care services and doula care services that seek healthy birth and delivery outcomes.
So just to be clear, the bill before us that we're considering today having to do with doulas, to go back to Delegate Kipke's question, this will not give any prescriptive authority to doulas. They would not, under any circumstances, be able to participate in that, as I read the bill before me right now.
We don't know yet, Delegate Kelly, because it establishes a bureaucratic process under the Maryland Department of Health and the certifying body. So the occupational boards will be able to determine what is within the scope of practice, the appropriate scope of practice for doulas moving forward.
I don't want to get into a back and forth, so I thank you, but I trust the committee to know how this process works. Thank you.
Thank you. And are there any other questions? I see none, but just for the record, to clarify, Section 2214 of Health General says a person may not be required to perform an abortion, but it also says not required to participate in an abortion. So it's quite clear in our law. Are there any other questions? Seeing none for this bill, this concludes the bill hearing on House Bill 765. Next, we also have House Bill 373. Thank you for all that were present today. We appreciate your testimony on the prior bill. Now we have 373, Delegate Resnick, State Postmortem Examiners Commission minimum staffing requirements.
Thank you, Madam Chair.
My pleasure.
Members of HGO. I'm here to present HB 373, which is a bill that would prohibit the Office of the Chief Medical Examiner, the OCME, from exceeding staffing to autopsy ratios that would cause a phase 2 violation with the office's accrediting body. So it's complicated, and so I want to take a few moments to explain what all of that means. As recent news reports have indicated, we literally have bodies piling up in Maryland. That is not an exaggeration. I wish it was. That is the literal truth. The Department of Health's OCME office has allowed staffing levels to drop so much that we are in a crisis dealing with the number of autopsies that need to be performed in a timely manner. DLS budget analysts have reported to my subcommittee on appropriations that OCME has been at a minimum of phase 1 violations for the last 10 years. A phase 1 violation means that the autopsy to staff ratio exceeds 250 autopsies per year. A phase 1 over the course of the last year, we have been well past a phase 2 violation. And this is not our first time in violation of phase 2, which is when the office's autopsy to a medical examiner ratio exceeds 325 autopsies per year. The current stat that was presented to me indicates that as of right now, we are at 390, 65 over the phase 2 violation. The only reason we are currently not in an actual phase 2 violation is because the National Association of Medical Examiners, NAME, has suspended investigations during the pandemic. Up until a few weeks ago, the office itself did not even have proper storage for the remains in their care, with the decedent's bodies literally being stacked in the offices of the halls for days at a time, if not longer. Only 2 weeks ago did the department finally procure 2 refrigerated storage trailers, providing proper storage for all remains within their care for the first time in months. Not only was the situation disrespectful, but improper storage risks spoiling the pathology of the autopsies, potentially defeating the purpose of the examinations themselves. The problem is so bad that the state has requested assistance from FEMA to help clear up the backlog. The department will be quick to point out that every state is experiencing shortages in pathologies, and that the problem isn't unique. However, to the best of my knowledge, we are the only state to have admitted, by virtue of this request, to having a full-fledged disaster on our hands, though a man-made one rather than natural. This is not a new problem. As chair of the Health and Social Services Subcommittee on Appropriations, I have had this discussion with the department every single year. For 6 years, I have heard the excuse that the positions are difficult to recruit. The department has not hired any new pathologists since 2019, well before COVID, and only this year has made any significant salary changes to the positions. Instead, the department has opted for per diem personnel to come in on nights and weekends, often flown in from other states at our expense to deal with the backlog. Last year, 5 pathologists retired, only to be rehired as per diems by the state office, getting a higher daily rate for clearing backlog cases that are less complex, creating an even larger morale problem within the office. Other pathologists have left the office to go to jurisdictions that either provide higher pay or a smaller caseload and better work-life balance. There is one error in the bill that needs to be corrected. The bill is written to hold the state's Postmortem Examination Commission responsible for implementation. The commission itself is a volunteer board assigned to provide oversight and assistance, but has no budget authority or ability to hire. It should be the Department of Health that is being held responsible, and I'm happy to offer an amendment to make that important correctional change. Otherwise, it really is time to hold the department accountable for their mistakes. And I ask a favorable report from the committee. Happy to answer any questions. I know it's a complicated issue, but I've been steeped in it for the last 12 months or so, and happy to have the conversation. So thank you all very much.
Thank you, Delegate Resnick, for your testimony today. Are there any questions for Delegate Resnick? Just take a minute to make sure I don't miss anyone. There are no questions, and there are actually no other witnesses orally. Everything is written. Thank you so much for your testimony today. We appreciate it. This concludes the bill hearing on House Bill 373. Members, next we're going to the last 2 bills. We have Delegate Lehman, House Bill 699, Office of the Chief Medical Examiner, Grief Counseling Services. Good afternoon, Delegate Lehman. Will you please get started? You have 5 minutes.
Yes, good afternoon, Madam Chair, Madam Vice Chair. Good afternoon, and esteemed members of the Health and Government Operations Committee. For the record, I'm Delegate Mary Lehman, and I am here to ask your favorable consideration of House Bill 699, a unique and much needed approach to grief support services for those who have lost a loved one to suicide or a fatal overdose. Under the amendment I have submitted, grief support will be provided through the Office of the Chief Medical Examiner rather than the Behavioral Health Administration for both individuals and OCME employees, and paid for by the Opioid Restitution Fund. This idea for the bill was actually brought to me by Johns Hopkins researchers whose life's work is to better understand and thereby prevent death by suicide, which they more broadly and I think compassionately refer to as death by self-harm. Death by self-harm includes overdose deaths that often are accidental. This dedicated group of researchers see grief support within the Office of the Chief Medical Examiner being a natural fit, since that agency is dealing with families and other loved ones in the aftermath of death by self-harm. OCME employees would also be able to access this much needed support because the work they do is so intense and so emotionally difficult. The OCME will house this program in consultation with the Maryland Behavioral Health Administration. As drafted, HB 699 had called for direct grief counseling services within BHA. However, that was not the original intent, and it doesn't make any sense actually because BHA does not provide direct services. So after speaking with MDH staff and behavioral health advocates, I submitted the amendment I described that models this grief counseling initiative after similar programs in New Mexico and the city of Philadelphia, where grief support is provided through the Office of the Chief Medical Examiner. While the state of Maryland has the 4th lowest suicide rate in the country, our suicide rate has increased from 19%, or has increased by 19% from 9.1 to 10.8 deaths per 100,000 population between 2015 and 2019. In 2018, suicide was the 11th leading cause of death in Maryland and the 2nd leading cause of death among 10 to 24-year-olds in the United States. Countless Maryland families have experienced the traumatic loss of a loved one by self-harm. My brother, David, died by suicide 11 years ago. So I know firsthand how incredibly difficult it is to process this kind of loss. Along with my 4 sisters and my mother, we struggled to understand why my brother's death at the age of 48, and he left behind 2 teenagers, we wondered how we had failed to see how despondent he had become. I stumbled along after he died, trying to function in a brand new job until my staff actually found counseling for me through an amazing organization that I believe you will hear from today. It's based in Howard County and it's called Grassroots. Even people with strong personal support systems may have no one equipped to help them, and many may not know where to turn. And that is where the OCME Grief Support Services program would come in. Individuals would be provided with resources on how to help process their grief. They would have a safe space to talk about their feelings, and these same resources and services will be available to OCME staff. As supporters of this bill will tell you, there is so much more work to be done to prevent death by self-harm and to deal with its devastating aftermath. I believe this bill is an important step forward in that effort, and I urge the committee to give House Bill 699 a favorable report. And thank you.
Thank you for your testimony today. Delegate Lehman, I know that was difficult. The committee does appreciate your experience, okay? And we're very sorry. Next, we have Ms. Cheryl Brooks. Ms. Brooks, are you here? Richard, oh, I see.
I'm
her
unmuted
there.
now, yes. Good afternoon, members of the Health and Government Operations Committee, and thank you, Vice Chair, for hearing us today. I am in favor of HB 699, which is being sponsored by Delegate Lehman. After my son died by suicide 8 years ago, Valentine's Day 2014, so we just passed 8 years. My first contact was with the coroner's office. And as a newly bereaved survivor, I needed all the help I could get. I didn't know what to ask. I didn't know what to do. I was just, I was in shock. And so any type of help would be truly appreciated at that time, because your first contact is very important. It's an important sense of solace to you. And you mentioned Grassroots. If it wasn't for Grassroots, I don't know where I'd be. because my husband and I have been in that group now for close to 8 years. So thank you. But grief counseling can save lives. Thank you. You need to be.
Thank you, Ms. Brooks, for your testimony. And again, the committee conveys, we're so sorry for your loss. And thank you for sharing your experience with us today. Okay. Next, we have Ms. Ashley Bagno.
Hi, my name is Ashley Badgley, and I am the Suicide Prevention and Postvention Coordinator at Grassroots Crisis Intervention Center that Cheryl just mentioned. I'm here to state that I'm in full support of HB 699. Suicide is a problem everywhere, but as someone who works in this field on a daily basis, I can tell you that Maryland struggles to meet the needs of those who have lost someone to suicide. The days, the weeks, the months, the years, they do not get easier, but we have the ability to make people stronger to be able to handle that grief. Survivors who carry the pain, for lack of a better term, those who carry that pain best are those who are able to talk to a professional about their grief. Suicide grief is unlike any other grief, and it requires specialized care and caution. We don't want them just talking to the medical examiner after the death of a loved one. Since I was asked to join this meeting last week, I have received at least 5 requests from folks in Howard County who have lost a loved one to suicide in the last few years to join our support group. And I say since, approximately, because I've received at least 1 request today that I have not been able to respond to. I have had a conversation in the last few days of someone who lost a loved one to suicide shortly before the pandemic and has been struggling since then to find somewhere to go. They are a Maryland resident, and I will be welcoming them to our support group, but our support group is not therapy. It is not one-on-one counseling. So I urge you to support this bill and ensure that the people of Maryland who have lost a loved one to suicide have free, qualified, and appropriate grief counseling. As Cheryl said, it will save lives and it will help erase the stigma that surrounds suicide and death by overdose. Thank you.
Thank you for the work you do. You're making a difference. We have Mr. Donald, and I apologize if I don't pronounce your name correctly. Is it Donald Bonin?
It's Bonin.
Yes, thank
Bonin,
you.
B-A-U-G-H.
Thank you, Mr. Bonin. Good afternoon. Will you get started?
Good afternoon. Thank you, distinguished members of the Health and Government Operations Committee. I'm here in support of House Bill 0699, which would offer no charge grief counseling services to next of kin in case of sudden death by suicide and or drug overdose. Access to grief counseling should be available to all in these cases, regardless of financial status. 8 years ago, my wife and I were in total state of shock and horror when we were informed of my son's sudden death by suicide. We were not aware of where to turn, where to go for support. Having access to no charge counseling services would have been most valuable during that time, which was the most difficult times in our lives. So having access to no charge grief counseling services would offer support to a growing number of Marylanders when such support is drastically needed. Once again, thank you for your time, and I'm urging support of HB 699. Thank you.
Thank you, sir, and I'm so sorry about your loss.
Thank you.
Next, we have Mr. Paul Nestak. Good afternoon.
Good afternoon, and thanks to the committee for having me here. So I'm Paul Nestak. I'm a psychiatrist, and I'm a suicide and opiate overdose researcher at Johns Hopkins, and I consult for Baltimore's Opioid Fatality Review Board. But I'm here not representing Johns Hopkins. I'm actually here as representative of the Maryland Psychiatric Society, which I'm a council member. I'm here in support of HB 699, proposing use of opioid restitution funds to support the OCME for grief counseling. As you've heard from Delegate Resnick earlier, the ME is stretched very, very thin. As he mentioned, the Washington Post reported on bodies piling up in a parking lot. But Dr. Whedon, the chief medical examiner, has been dutifully working to fulfill the mission of the office, which involves tending to the aftermath of the opioid crisis, including the grief left in the wreckage of these deaths. I've worked with the past 3 chief medical examiners on various epidemiologic projects to better understand the roots of overdose and suicide. But in between data sharing conversations, each has always asked me, because I'm a mental health worker, how they can answer the grief in the eyes of the next of kin who come to identify and collect bodies. This is something that is difficult for them because resources are scarce. But now, thanks to the opioid restitution funds, there's an opportunity to use these funds and put them to a good use. These are funds that were earmarked to repair a community that was destroyed by overdoses. This includes helping with substance use treatment. It includes using those funds to research and understand to prevent substance dependency and overdose. But for the thousands of Marylanders who have died each year by overdose and suicide, these funds come too late. But they come at the perfect time for the grieving families left behind that are struggling to find care. This proposal would support the OCME to provide much needed healing for those in mourning. It would help the OCME provide resources and referrals to counseling, and would bolster existing grief counseling services. We owe this to the people of Maryland, especially the most vulnerable, now in their time of greatest need, mourning their loved ones. So I urge you to vote in favor of HB 699. Thank you.
Thank you, Dr. Nesta, for your time and for your work. Next, we have Ms. Allison Atay.
Thank you, Madam Chair, and thank you to the members of the Health and Government Operations Committee. Thank you also to the bill sponsor, Delegate Lehman, and the other survivors who've shared today. I'm Dr. Allison Atay. I'm a research fellow at Johns Hopkins University and a clinical psychologist. I study suicide and overdose prevention, as well as the experiences of those bereaved by self-harm deaths. I also treat patients who are working to build lives worth living through mental health crises and following the loss of loved ones. I support House Bill 699 because it lays a foundation for sustainable services for more than 15,000 Maryland families that experience traumatic bereavement annually. Research shows that survivors of traumatic bereavement experience significant physical, mental health, financial, housing, and school or work difficulties following the loss of a loved one. Children and older adults may be especially vulnerable to poor outcomes after suicide and overdose deaths. Unfortunately, we know that Black Marylanders are disproportionately burdened with traumatic grief because of inequities in the increasing rates of suicide and overdose deaths in these communities, especially during the pandemic. Research shows that treatments for traumatic bereavement work. I believe that treatment may be one way to prevent the transmission of risk for suicide and overdose through families and through communities. To my knowledge, there are no public resources dedicated to ensuring enduring support for survivors of suicide and other traumatic losses here in Maryland. This work often falls to untrained first responders and staff at the Office of the Chief Medical Examiner, who, as we heard, are stretched very thin. Community bereavement groups have shared with me that there are significant barriers to connecting with the most vulnerable survivors and with specialized educational courses. We know that opioids have increased the rates of both overdose deaths and non-overdose suicide deaths. I believe that the opioid restitution funds could be used to break the cycles of traumatic deaths and to create cycles of healing in bereaved families and communities. And I urge a favorable report on House Bill 699. Thank you.
Thank you, Dr. Atay. We really appreciate your testimony and your time today. We're now going to open it up for questions. Are there any questions from the committee? One second, I'm just looking, making sure I don't miss anyone. There is Dr. Hill, Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Lehman, for bringing this bill. I guess this question I want to direct towards Dr. Is it Nesbitt? Nesser?
Nesbitt, that's fine.
Nesbitt, okay. Recognizing that, we don't have enough grief services available, and that a small percentage of deaths end up going through the medical examiner's office. I'm trying to understand two things: why you think this is the proper place for a grief program as opposed to, say, a chaplaincy program and support training for the staff. Well, let's just leave it at that. Why is the medical examiner's office where you would put a full grief program and not a chaplaincy program and support for the staff?
That's a great question. So I think the important part is which small percentage of those deaths go to the medical examiner's office. So the ME looks at all unnatural deaths. This includes overdoses, homicides, suicides, basically, essentially what it is, motor vehicle accidents as well. So the vast majority of deaths in Maryland are natural deaths, which you can imagine. The bereavement from a traumatic death, like an overdose or a homicide or a suicide victim, is a special type of grief that requires a lot of care, as Dr. Athey alluded to. The feelings of guilt that you've heard about from some of the other speakers in the panel, and the feelings of just what could I have done, need special care. The medical examiner takes care of these patients' bodies, and when the family shows up, they are basically at a loss, and it's very hard to find resources like the chaplain or finding grassroots, for instance. The delegate Lehman, mentioned that she was directed to grassroots thanks to her staff finding that organization. She had a whole, the staff of a politician to find her this organization. The medical examiner would be able to direct people directly there to places like grassroots. There's a variety of other organizations in Baltimore. It's people like Roberta's House. The medical examiner would help get them there because they're the only ones seeing these people in traumatic grief. I think that's the important take home point and why they're so important.
And Madam Chair, if I could follow up. So I just want to be clear, what you're saying is traumatic deaths, suicide, homicide, accidental dramatic deaths, there is a nexus there that all the families or the vast majority of families affected are going to pass through the medical examiner's office and have access to this information, potential service. You're saying that's the one place where they actually do pass a common point?
Yeah, and it's not almost all, it's all of them. The Maryland is actually very good compared to other states at having the statewide medical examiner's office. It's very comprehensive. Every one of these deaths goes through, gets a full autopsy and toxicology. It's why there's kind of a backlog. It's inefficient, but it is what we do. And that's why it's so important to have that organization there. I'd also point out that there already does exist such a service for homicide deaths. There's grief services that are made available, that are legislated for various programs for homicide victims, which is important as well. But that's the reason that group is not on this bill, just to point that out.
All right, thank you.
Thank you for the questions, Delegate Lewis.
Thank you, Madam Chair. Thank you to Delegate Lehman for bringing this bill. And thanks to all of the panelists who testified and shared their intensely personal stories. We try in this committee to honor the experiences that people have and just know that we hear you and we care about you and we want to make it so that no one else has to go through these difficulties. My question is for whoever's best poised to answer this. Do we have information from other states that have implemented medical examiner office-based grief counseling? Because I was also, like Delegate Hill, curious about whether the MD's office is the best place. So what can we learn from other states? And whoever, again, is best poised to answer.
So who's the best person in this committee? We allow only one person from the panelists to address it. So Delegate Lehman, who's the best person?
All I wanted to say briefly, I'm not sure who the best person is, but I do want to reiterate what I said in my testimony, that we know of at least 2 jurisdictions that offer the counseling through the Office of the Chief Medical Examiner. I believe the state of New Mexico pioneered this, but the city of Philadelphia does it as well. But I would ask either Allison or Dr. Nestat.
No, but it's okay. You answer already, so we can get it offline as well.
Thank you, Madam
Thank
Chair.
you. And I saw Dr. Athey shake her head that you were correct. Any other questions, Delegate Lewis? Delegate Bandari.
Well, thank you, Madam Chair, and thank you, Delegate Lehman, for this wonderful bill. And there is a concern from MDH that BHA, Behavioral Health Administration, will not be the agency responsible for establishing grief counseling program. I wonder if MDH offer any alternative during your meeting.
Thank you for the question, Delegate Bandari. What they said to me is that they, thought that the concept was a good one, but wanted to make clear that that agency does not offer direct services. There was in the process of coming up with the concept for the bill and working with your wonderful HGO staff, there was sort of a missed communication about what had initially been my idea to have coordination or consultation through BHA, but have the services, actually the grief counseling services, done at the local level. But then in talking to the Department of Health and these other advocates, because I had learned through the Johns Hopkins folks that there were a couple of jurisdictions providing this kind of these kind of services through OCME, that I thought it should be housed there. The initial contact, as Dr. Neustadt said, all families that lose loved ones to self-harm, to suicide or overdose, all of them, 100% are dealing initially. The first interaction they have with government is the Office of the Chief Medical Examiner. So that part made sense. And then it was brought to my attention that not only obviously I know individuals need this kind of help, my family needed this kind of help, but also employees of OCME, because of the nature of the work they are doing, and the just sort of the rawness of that, the difficulty of it emotionally, and then add to that the fact that there are staffing challenges, that they also could benefit from this service being, sort of the term that was used with me was embedded, grief counselors, social workers within that agency. Does that answer your question?
Yeah, absolutely. Thank you.
Thank you for asking.
Any other questions for Delegate Lehman and her panel? Seeing none, thank you, Delegate Lehman, for bringing your panel to us. Thank you, everyone, for sharing your personal experiences. Again, we're sorry for your loss, and have a blessed evening, okay?
Thank you.
Our pleasure. We have our final bill of the day. It is an administration bill. It's actually House Bill 408, and it's titled Statewide Targeted Overdose Prevention Stop Act of 2022. I understand that Jake Whitaker is testifying for the administration. Is that correct, Mr. Whitaker?
That's correct, Madam Vice Chair. I'm also joined by Robin Ricard, as well as Aaron Russell from the Maryland Department of Health.
Okay, wonderful. So good afternoon.
Hi, Madam Vice Chair, Madam Chair, members of the committee. My name is Jake Whitaker with the Governor's Legislative Office, here to testify in support of House Bill 408. House Bill 408 requires healthcare facilities and other entities, including hospital emergency departments, treatment facilities, homeless service providers, and correctional facilities, make naloxone available to individuals at risk of an opioid overdose. Since 2017, over 2,000 Marylanders have passed away as a result of opioid overdoses each year. Naloxone is a fast-acting opioid reversal drug, and expanding access to naloxone is key to reducing opioid-related fatalities. Research has shown that for every 60,000 doses distributed, more than 300 lives could be saved. This bill is important because naloxone is most effective when readily accessible to people who are likely to experience or witness an overdose. Data shows that individuals who receive naloxone to reverse an opioid overdose are much more likely to get connected with healthcare treatments and other resources. So for the aforementioned reasons, we respectfully ask for a favorable report on House Bill 408. And if okay with you, Madam Vice Chair, I'd like to turn the rest of my time over to Robin Ricard.
Absolutely. Good afternoon, Mr. Ricker. Can you get started?
Good afternoon, Chair Pendergrass.
Oh, Ms. Ricker, how are you?
It's fine. I get that a lot. It's fine.
It's okay. I apologize. I would never forget.
Good afternoon, Chair Pendergrass and Vice Chair Melnick and members of the community. My name is Robin Ricard, Executive Director of the Opioid Operational Command Center, and I'm here to testify to support House Bill 408, the Statewide Targeted Overdose Prevention Act of 2022, and it's an honor to be before all of you again. As was mentioned, the opioid crisis continues to claim the lives of far too many Marylanders each year. Naloxone is a safe and easy to use medication that can reverse an overdose, preventing death. Naloxone is not a controlled substance and has no potential for abuse. Targeted naloxone distribution is defined as providing naloxone to those at the greatest risk of experiencing or witnessing an overdose. And expanding targeted naloxone distribution is a priority of our office. Maryland has done a tremendous job in establishing an infrastructure to support targeted naloxone distribution, but gaps remain in reaching those at the highest risk of overdose. Through the passage of the STOP Act of 2022, certain systems, including emergency medical service providers, hospitals, behavioral health treatment providers, correctional settings, and homeless services organizations would be authorized or required to offer naloxone to individuals at risk of overdose. Entities named in the legislation were identified based upon extensive research and data presented in the Data-Informed Overdose Risk Mitigation 2020 Annual Report. The DORM initiative formed out of the passage of the Chapter 211 Act of 2018 requires the Department of Health to create overdose risk profiles using linked data sets from individuals who died from an overdose. High-level findings from the DORM report showed that nearly 70% of individuals who died from an overdose between 2016 and 2020 had an interaction with a Maryland hospital in the 4 years preceding their death. Additionally, overdose decedents who received outpatient mental health services in the public behavioral health system within 30 days of their death were more likely to be active in both mental health and substance use disorder services. There's also extensive literature that identifies that justice-involved populations are at greater risk of fatal overdose as compared to the general population. Colleagues from the Johns Hopkins Bloomberg School of Public Health found that in Maryland, individuals released from the prison system were 4 times more likely than the general public to die from an opioid overdose. And those engaged with parole and probation were 2 and 1/4 times more likely to die from a fatal overdose. Requiring these named entities to offer naloxone to individuals they serve is critical to ensuring that naloxone is made available to those who need it the most. And as Maryland continues to employ an all hands on deck response to the opioid and overdose crisis, we believe that passing the STOP Act of 2022 is a critical step in reducing overdose related mortality. And with that, I urge a favorable report for House Bill 408. And Madam Chair and Madam Vice Chair, if it's okay with you at this time, I'd like to turn it over to my colleague, Erin Russell, Chief of the Center for Harm Reduction Services at the Maryland Department of Health.
Not a problem. Ms. Russell.
Thank you. Good afternoon, Chair Pendergrass, Vice Chair Pena-Melnick, and members of the committee. My name is Erin Russell. I lead the Center for Harm Reduction Services at the Maryland Department of Health. We are responsible for the Overdose Response Program, which means approving, supporting, and monitoring local entities that get naloxone out into the community. We also currently purchase all of the naloxone for this community distribution. The department is in support of House Bill 408, along with the proposed amendments. The STOP Act presents an opportunity to efficiently accelerate access to naloxone. Modeling studies show that when widely available in high-risk settings, we can reduce rates of overdose deaths in our state by 30%. As you heard, all of the agencies identified in the STOP Act were found through research on high-risk factors, notably recent periods of abstinence, previous non-fatal overdose, and co-occurring mental health disorders. And in 2021, just about 20% of people who got naloxone in Maryland were trained by those agencies, a really small fraction of the total people that they serve. So despite years of investment and the overwhelming evidence that naloxone stops overdose deaths, it's clear that agencies in Maryland engaging high-risk individuals are not systematically offering it. This bill resolves that issue. I'll also add that legislative action to compel agencies to offer naloxone is imperative to address the gap and backed by published evaluations of naloxone mandates that show they work to rapidly expand access. This bill's greatest impact will be seen among vulnerable communities who do not have access to traditional healthcare services or insurance coverage. They will have naloxone placed in their hands by the systems and agencies they are already encountering. Finally, the STOP Act of 2022 builds on existing statute and structure. The Overdose Response Program has the infrastructure in place to institutionalize naloxone distribution, purchase the medication, and track gaps. Thank you again for your time and consideration. We request a favorable report.
My pleasure. I have Ms. Stacy McKenna.
Hello, I'm Stacy McKenna. Can you hear me?
Yes.
Thank you for Thank you for hearing us today. I'm a harm reduction policy researcher with the R Street Institute, which is a nonprofit, nonpartisan think tank. And we are speaking in support of House Bill 408. I can mostly just reiterate and support what the folks that came before me said. But I want to add that this type of program, the benefits are not just hypothetical. We've seen similar efforts in other states that have demonstrated considerable success. Vermont is one example, and they found that uptake was really high. So when they looked specifically at programs in which emergency services folks were offering naloxone, 85.5% of those offered the medication accepted it. And they estimate that the program prevented at least 279 deaths in 2020 alone. So we have evidence from other states. And as others have said, this is based on clear research suggesting that it's going to reach the most vulnerable populations in the places that they're already accessing services. So again, R Street Institute urges favorable support of HB 408. And thank you for your time.
Thank you for your testimony. We appreciate it. Next, we have Ms. Ansika. Actually, that's favorable with amendment. Let's take questions of the favorable. Are there any questions? I see Delegate Kipke.
Thank you, Madam Chairman.
My pleasure.
To someone from the department, I've been encouraged to seek an amendment to the bill and to your proposed amendments to not speak specifically to a particular treatment, but instead to eliminate the specific treatment and replace it with FDA-approved overdose reversal drugs to give the department flexibility as new products come on the market. I'm curious as to have you reviewed that proposed amendment or that proposed change? And do you have any feedback for the committee?
So Delegate, if okay with you, I can answer that question. So some stakeholders have reached out to us. Our understanding is that in the future, there may be other drugs that aren't naloxone that may assist with opioid reversal or overdose reversals. So we are open to language that expands the number of drugs that are available to assist with this issue.
Okay, great. I'll send this information over to council. Thank you very much, Madam Chairman.
My pleasure, Delegate. Thank you for your question. Next, I have Delegate Bandari.
Well, thank you, Madam Chair. Jack or anybody who could answer. I'm not sure if you have seen the Johns Hopkins suggestions. They are, I don't think they're concerned, but they are saying that if the state is requiring expanded this naloxone distribution, the state should provide the naloxone to all of the program listed in the bill. That's number one. Number two is about the supply side. And number three, a naloxone training requirement. I wonder if you are aware of their suggestions.
Delegate, I'm not aware of their specific suggestions, but I can turn it over to Aaron, who could speak more closely to kind of the program that we have in place at MDH.
Sure.
So currently there are no training requirements in statute. It is up to the discretion of the prescriber of naloxone, who establishes a relationship with a program and writes standing orders for the distribution of naloxone under their prescribing authority. So currently that is the structure of the program, and we provide assistance to all local programs to determine the ways in which they will train and educate and distribute the drug.
So could you speak on the supply side?
We currently purchase naloxone for all of the community-based organizations that are registered with us as overdose response programs. So we have centralized that purchasing at the state, leveraging our purchasing power through the MCAP, and Cardinal Health is the distributor. So we can purchase the drug at a discounted price and ship it directly to the local organizations. And we'll continue to do that as our budget allows.
Thank you.
Thank you, Ms. Russell. Thank you, Delegate, for your questions. Any other question for this favorable panel? Seeing none, we're going to go now to the favorable with amendment. I have first Ms. Ensika.
Thank you, Madam Chair. Members of the committee, I'm Ann Seacott on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. We absolutely support ensuring more naloxone gets out into the community, and we very much appreciate the department's focus using data to help drive these policies. We're grateful that the administration has also been willing to discuss amendments with us. We support what they have proposed to make so that we're not creating an unfunded mandate, especially on any of the small community-based nonprofits that might be included in the bill. We're seeking a couple of others, and we're going back and forth, and we'll work it out with the administration and with the subcommittee. But we want some clarification on needing a new definition of community service programs in the bill in section 8408, and it combines two levels of licensed healthcare providers along with other community-based services, human services. We're just not sure why these two levels of healthcare are pulled out and put in this new section when it appears to us that it's covered already in section 133104 in the bill. And then finally, we actually don't believe that putting the effective date of July 2024 is needed in terms of having these programs, having these protocols in place. The crisis is now, and especially for any of the healthcare facilities, if they're not doing this already, they should, and they probably are to some degree. And if they need to do it more, NCADD does not believe that 2 years is necessary. So we would propose potentially speeding up that timeline. So we're looking forward to working with everybody on making this an even better bill.
Thank you. If you could please make yourself available and try to work it out. Really appreciate it. We also have Ms. Lori Doyle, but I don't see her here. Richard, she's not in yet, right?
No, ma'am. In finance.
And she testified favorable with amendments. So are there any questions for Ms. Seacott from the committee? I don't see any. Thank you so much for your testimony on House Bill 408. I appreciate you trying to work it out, and we appreciate your testimony. I want to thank the administration. This will actually conclude the bill hearing on House Bill 408. And before everyone leaves, I have a subcommittee reminder. There is a health occupations meeting immediately after this bill hearing. So please make sure that you get the link and that you're present. I really appreciate it. This concludes the work for today. And thank you so much for being with us.